Good afternoon. This is Emily Henderson, pharmacist with the Kentucky Hospital Association. Thank you for joining today's Kentucky SOS or Statewide Opioid Stewardship Program's webinar entitled Battling Kentucky's Opioid Crisis, Choose PT. All lines are muted. However, you can unmute your phone at the conclusion of the presentation to ask questions. You may also utilize the chat box for questions during the presentation. As always, the presentation slides and webinar recording will be posted on the Kentucky SOS website for your reference or to share with colleagues about 1 week after today's webinar. I will also email to all Kentucky SOS project leads the slides and recording once they're posted on the website. So welcome to today's Kentucky SOS webinar. And this webinar is the first in a series of 4 monthly webinars ending in July, focusing on the following topics: physical therapy as an alternative to opioids, inpatient multimodal analgesic order sets, perioperative opioid stewardship and changing the culture, and proper prescription disposal and education. Kentucky SOS collaborated with Baptist Health clinicians for this webinar series, and it exemplifies best practices for opioid stewardship programs. It's been a true multidisciplinary approach representing pharmacy, physical therapy, nursing, and medicine disciplines. So today I have the honor of introducing the presenters for today's webinar, all physical therapists and active members of the Kentucky chapter of American Physical Therapy Association. From Baptist Health Lexington, Charlie Workman. From Baptist Health Paducah, Mike Muscarella. And consultant CEO of Johnson PT Consulting, Holly Johnson. Charlie?
Okay, hopefully everyone will be able to see my screen. I want to start off by saying that on behalf of the collaborative effort with the Kentucky Hospital Association and the Statewide Opioid Initiative, the Kentucky Physical Therapy Association, we're very honored to have the opportunity to be able to talk with you guys today on the opioid crisis. Just a brief background on me. My name is Charlie Workman. I currently serve as president for APTA Kentucky chapter. I currently work at Baptist Health as the executive director for the Cancer Center, but have been at Baptist Health in the rehab department. It's been a little over 2 years since I've been part of the rehab department there, but I've also had the opportunity to work in the inpatient rehab facility setting, outpatient rehab, and home care as well. So I've had the opportunity to understand some of the operations in multiple levels of care across the continuum, learn some of those nuances on criteria and eligibility for receiving care in each of those settings. So it's a privilege to be able to talk with you guys today. The purpose of our talk is to hopefully kind of recalibrate you to some of the opioid issues that continue to burden our state today, and hopefully offer some additional resources to consider potential alternatives for pain management, particularly for those patients that show up in the ED or ambulatory care settings. So our objectives for today, there we go, demonstrate an understanding of the alternative treatment strategies for patients with chronic pain and musculoskeletal disorders, and demonstrate a basic understanding of how the physical therapist can be a part of that multidisciplinary team to help treat and manage chronic pain. To start with, we need to begin looking at how Kentucky stacks up relative to the United States in general as it relates to drug deaths or deaths related to drugs, whether they be unintentional, suicide, homicide, undetermined, per 100,000 population. So if you look at the graph on the screen, Kentucky is the top line and the United States is the lower line. Currently, Kentucky ranks 42nd with 31.3 deaths out of 100,000. And that's according to America's Health Rankings data from 2021. So we have work to do, definitely. The individuals in our state that are at higher risk of drug overdose, males, have twice the rate of drug overdose deaths compared to our counterpart females. And then adults between the ages of 35 to 44 have some of the highest rates of drug overdose deaths compared to the other age groups. So there are a number of contributing factors that we're going to mention today. Reports of mental distress continues to increase, and certainly during the time that you see on the graph here between 2015 and 2020, mental distress increased by 26% reported in Kentucky. And then we also have a higher prevalence of multiple chronic conditions that leads to a secondary sedentary lifestyle, obesity, and malnutrition that are all linked to drug-related deaths. So as you can see, we experienced a bit of a dip in 2017 in the battle to help kind of stem the opioid crisis overall. There were a number of federal and state regulations that were put into place. A few of those implementing prescription drug monitoring programs at a state level to reduce the opioid prescribing, increasing the distribution of naloxone, improving the access to drug treatment, supporting law enforcement strategies to reduce illicit opioid supply out there, and then guidelines for prescribing opioids for chronic pain, as well as prescription checklists that have you consider alternatives before prescribing opioids. And so here's what we know, some key findings. In 2017, we saw an overprescription of opioids to post-surgical pain for people receiving procedures like rotator cuff repair, hip surgery, et cetera. But our patients were in Kentucky were being prescribed an average of 82 pills to help treat that pain for those common procedures. Of those, more than half of the ortho surgery patients received opioids that were more potent than what the CDC had recommended. And we also had a report of 12% of patients that had self-reported becoming addicted or dependent on those opioids following surgery. So our state continues to kind of lag behind in the number of pills per resident. So we have work to do, definitely. We still have one of the highest number of opioid pills per resident relative to the average across the United States. So these are some of the efforts that we're trying to improve on. To make, though we made progress in 2017 and even into 2018, we were able to reduce the total number of deaths by 4.1% from 2017 to 2018, down to 315 that were opioid prescription specific. But while all that headway was being made between 2017 and 2019, as we all know, 2020 comes, and in February of that year, Kentucky started to experience the COVID epidemic that took center stage. And in that undercurrent, we saw a greater than 50% increase in the number of drug-related deaths that occurred in Kentucky, according to our Kentucky Cabinet of Public Safety and Drug Control. So we jumped from 415 to greater than 1,900 deaths as COVID kind of took that center stage there. So nationally, if we look across the board, there were greater than 93,000 deaths during that 12-month period, which was the highest ever reported. So these are numbers that heavily burden our healthcare system, in addition to the COVID pandemic that continues to swirl. So if we look specifically at some of the highest negative contributors to drug-related deaths in Kentucky, and as you look at the illustration here, I took a snapshot of the bottom of the graph. We can see a number of adverse behavioral components that I think are of interest, where Kentucky ranks the lowest of all states. A few of those opportunities are of particular interest to physical therapy. Certainly physical inactivity, frequent physical distress that we'll talk about, lack of exercise, and in turn that results in a higher prevalence of multiple chronic conditions. So this suggests that we need to have an interdisciplinary approach to how we're addressing our opioid crisis. Early intervention to physical therapy should be among the preferred options to help address the crisis that we're facing. If we look at the map across the United States here, this is not the big blue that we could really be proud of. As you can see, we have a high percentage of adults who reported that their physical distress and their physical health was not good 14 or more days out of the past 30 days. And we are ranked 49th, just next to our ranked 50th partners here, West Virginia. So why does this matter? We need to kind of capture the population that's experiencing this persistent physical health related problems that may be a significant impact to the health related quality of life and overall wellness that they're experiencing. These issues, I think, contribute to the dependency on medications to control the pain. So if we start looking at the physical distress that our population here in Kentucky is addressing, we might be able to curb some of the medications that are going out to try to address the problem. People are at risk of developing more chronic conditions, cardiovascular disease, cancers, diabetes, obesity, severe arthritis that can progressively impair their mobility, resulting in a dependency on medications to help control their pain. So with the high level of physical distress and mental distress, it leads to a downward spiral of physical activity and, as I mentioned, more chronic health conditions. These individuals are the ones that are kind of showing up into the emergency department seeking care from teams that are already on the front lines of dealing with the COVID crisis as well as the opioid crisis. And many departments are just becoming overwhelmed with the number of patients that they see walking in the doors. And this is where we feel like PT can be of help, with other providers having limited time to be able to address some of these chronic conditions, musculoskeletal conditions, and functional decline. A consult to physical therapy right there in the ED can offer support to our ED team as a whole that needs to focus more on some of the traumatic injuries that are coming in, strokes, heart attacks, motor vehicle accidents, things like that. So we want to work as an interdisciplinary team to offer the best that we can for these patients as they come into the ED. A quick story. And now it's been a little over 2 years since I was part of the rehab department here at Baptist Health, but we had a patient that had arrived in the ED in a wheelchair that had limited mobility. She was not able to walk more than 10 to 20 feet, required moderate assist to be able to even transition from the wheelchair to standing or even in the bed. So the nurses and I had worked together to kind of get her transitioning from the wheelchair to the bed. She had reported 10 out of 10 pain and was very apprehensive to movement. And so once the patient was cleared by our physician that there was no traumatic incident that was causing her pain, I was asked to consult to determine whether this person was an appropriate admit to the hospital or would there be a more appropriate next level of care for the patient to consider. So on examination, this was a 38-year-old female who was 240, 250 pounds, who had been dealing with pain for a couple of years, and she just progressively had limited her mobility over and over and over. She was on a slew of medications already. She had very limited mobility, very limited ability to even do basic ADLs, cleanliness for herself, taking care of her home, and was very dependent on the pain medications to try to get her through the day. So her immobility had contributed to other pains that she was describing as we went through the examination. She had postural pain. She had a lot of muscle spasms that were going on, contractures in her lower extremities where she had sat for such a long period of time, which made her just experience more and more and more pain. So we really spent a lot of time and effort educating her on the importance of mobility and how that can help contribute to getting her back to her normal routine and goals. Her goal was to try to make it from her house to her car so she could return to driving and get back out into the community. So she had some very clear asks to try to make improvements. But she also described the medications as being something that was really like counterterrorism on her brain. She just knew that she was taking too much. She was asking for help. And so we were able to spend quite a bit of time with her, coordinate getting home health set up for her. Then she moved on to outpatient rehab. We also had consult from a nutritionist to help get her diet back in place. But we educated her on the importance of mobility to help reduce the pain that she was actually feeling. Initially, her movements were painful, but as she began moving more, she made improvements in blood flow. Her diet had improved. Endorphins began getting released, the body's natural painkillers, right? So she was able to start building and getting back to a regular routine. that she felt like was herself. So I think that was an opportunity, or as an example of how physical therapy can play a role in the emergency department, to spend a little bit more time with those patients that need to build some trust in what they are receiving from the emergency department. Oftentimes, I think culturally, patients expect to come into the ED, have imaging and more medications provided. So we have an opportunity to break that paradigm. When we look at some of the literature, we can see that some of the leading causes of patients presenting to the ED are musculoskeletal related pain. Low back pain is a major part of that, that PTs are well adapted and trained to address. So providers feel a little bit trapped with limited resources at times, and the need for patient satisfaction to be sure that their needs are met, that they can leave. But it's a challenge. For some facilities, you might hear them say, that's not what we do. We don't provide those extra services in the ED. We get folks in, we assess whether they're traumatic, and we determine the next level of care. For others, they consider it to be a larger issue. And if we start opening up that program, does that mean we're going to have more of those folks coming in? But the reality is these people are still coming in. And so we need to find optimal ways to be able to, and care strategies to be able to address those needs. So PT is one option to help reduce the costly admits if we can get them better directed to the appropriate level of care, and to avoid further deterioration of those patients that kind of spirals them down into having more comorbidities and decreased functional mobility. So if we address some of these high contributors that negatively impact our drug-related death strategies, then hopefully we can kind of play more of the long game in working with those patients to recover, versus more of a short game medication approach overall. So what are some of the benefits that are reported in literature and testimonials that we hear from PTs that have been implemented in emergency departments? There was a study out of the University of Utah that looked at about 600 patients. 380 of those, just a little more, that came in with musculoskeletal related pain, received physical therapy right there in the ED, where the others did not. And some of the results you see here on this slide, they had a decreased number of imaging procedures, and that's x-rays. Between the two groups, the CT scanning and the MRI, there was no significant difference between those, but decreased number of injections, improved patient satisfaction overall, to have a game plan for what do they do after they leave the ED? What is the next step? How can somebody else assist them in achieving their goals? Decreased wait time. So the workflow within the ED clinics, freeing up the physicians and the rest of the team to be able to work on more emerging cases, was a realization from this. And then those that received physical therapy had a reduced number of opioids that were actually administered or prescribed to them. So I think there is some opportunity for individuals that are appropriate for a physical therapy consult. I will say that due to EMTALA guidelines, you need to have a practicing provider first triage those patients. PT is not a qualifier, so we can be consulted in the emergency department, but we need to work as a team to understand, once they've been cleared of any traumatic injury and cleared by the medical team, we can come in and consult secondary to that. There are some other ways in which physical therapy might be of help. Certainly, I've been consulted for sprains and strains and dislocated ankles, dislocated shoulders, fall risk assessments, putting braces and splints and DME equipment assessment, chronic pain related stuff, and vertigo is another common request for a consult. Of course, neck and low back pain is probably the predominant reason that we often get triaged or that we often get consulted into the room, into the ED room. But there are challenges for physical therapy. It does require some resources, because the hospital obviously has to consider, how do we address care across the entire house? And if you have a therapist that's already been given a caseload on inpatients, it's difficult to work your way down to the emergency department, or to work your way over to PACU to address these additional add-ons. Patients aren't coming into the emergency department scheduling appointments. So you'll have these waxing and waning of, a rush of patients that might come in. It might be during lunchtime, it might be late in the day. So there are some challenges in setting up physical therapy strategically to best utilize the resources that are available in-house to treat all patients. But the physical therapist also needs to understand that we need to be flexible in addressing the emergency department needs when it's there, and making use of downtime by treating other patients as we're able. PTs have a unique skill set overall in understanding the continuum of care and certainly understanding the functional requirements for each level of care. So inpatient rehab, what is the functional status that qualifies them to enter into that level of care versus a skilled nursing facility that focuses either on long-term care or rehab. Home health has specific criteria that's recently changed actually, and so we need to keep up with those requirements as well as outpatient services as well. So physical therapy is very attuned to those criteria for each level of care. It can assist with making determinations for what's the right place to get that patient at the right time. Providing ongoing exercise programs to, if a patient is going to be discharged back to the community, with a home program or an action plan that they can continue to follow up with, rather than just being let go from the department as a whole. So one of the benefits of COVID has been that the waiver for multi-night stays in acute care environments had been lifted. So that gives us a little more flexibility to be able to get somebody into a skilled nursing facility or IRF level of care. So physical therapists are also very attuned to social determinants of health, as well as insurance barriers or facility and insurance criteria that are required to be met prior to being able to get a patient admitted to another level of care. So with that in mind, I'm going to transition the talk over to Mike Muscarella, and he can give you a little bit more in-depth explanation of how PT got engaged in this opioid crisis and some of the steps that we're doing both locally and nationally to address the issue. Mike?
Thanks, Charlie. And I'm going to have you stop sharing, and I'm going to share my screen. And let me pull up that share. Very good. Well, it's an honor to be here today and to be speaking with Holly and Charlie. They are outstanding physical therapists, not only in our state, but in the nation. And again, my name is Mike Muscarella, and I'm one of the executive directors here at Baptist Health Paducah, and I'm over the ambulatory services division. I'm a physical therapist by trade, and I'm also a licensed diabetes educator. You know, I work with our directors that are in wound care, respiratory care, and rehab services in those three departments, along with palliative care and advanced care planning. I was honored to serve as the president of the American Physical Therapy Association Kentucky chapter, serving the therapists and the assistants of the Commonwealth from 2012 and 2014, a position, as Charlie has mentioned, he is serving currently. I've also had the privilege of helping develop the physical therapy program at Western Kentucky University and serve on their advisory board. And I've also helped develop the occupational therapy program at Murray State University here at the Paducah campus to improve access to care for OT and PT services in the western part of the state. Let's see here. There we go. Pain is a problem. And the National Center for Health Statistics conducted a chronic pain survey of over 3,100 men and women back in 2019. The results showed that the prevalence of chronic pain was 20.4%, and the prevalence of high impact chronic pain was 7.4%. So you're looking at right at 29% when you add those two together of folks experiencing chronic pain. And of course, high impact chronic pain is the kind of pain that prevents you from doing functional and educational and employable and recreational activities. And the study also showed that women were more likely to have chronic pain and high impact pain than when you compare them to men. So where do we as physical therapists come in? You know, we're part of the interdisciplinary team. We provide education and treatment that is focused in part on movement as a specialty skill set in physical therapy practice. The American Physical Therapy Association's effort to make a positive impact on the opioid epidemic began in late 2015 when the APTA leaders met with the Obama administration. The Obama White House identified APTA's official consumer information website as a valuable tool to raise awareness among the general public about the benefits of physical therapy. APTA was asked to join the Obama administration's opioid working group and began preparing a campaign that ultimately led to the consumer web link www.choosept.com. In March 2016, the CDC released opioid prescription guidelines recommending non-opioid approaches to the treatment of most chronic pain conditions. And physical therapy was one of the recommended safe alternatives. This issue is as important as ever, as Charlie has pointed out. The CDC's National Center for Injury Prevention and Control is in the process of updating the 2016 guidelines. As of today, the draft was available for public comment in the Federal Register through, I think it was Monday, April 11th, 2022. In the original report, it was stated that although there are perceptions that opioid therapy for chronic pain is less expensive than more time-intensive non-pharmacologic management approaches, many pain treatments, including acetaminophen, nonsteroidal anti-inflammatories, antidepressants, and massage therapy are associated with lower mean and median annual costs compared with opioid therapy. The report also identified physical therapy as having a lower median annual cost when you compare it to opioid therapy. The APTA's hashtag #ChoosePT campaign recommendations are consistent with the CDC guidelines of when to choose physical therapy. So you really want to look at physical therapy when the risks of opioids outweigh the rewards. You also want to look at it when the patient wants to do more than mask the sensation of pain. And thirdly, you want to look at physical therapy when the pain of functional problems are related to low back pain, hip or knee osteoarthritis, and fibromyalgia. Charlie also pointed that about low back pain. So these are areas that we've demonstrated success in caring for control of pain. You also want to choose PT when opioids are prescribed for pain. Use physical therapy in combination with an opioid treatment regimen as well. So you have non-opioid therapy working with opioid therapy in tandem, and you get better results. Lastly, if the pain is chronic or has lasted longer than 90 days, you really need to look at having physical therapy for the patient suffering that pain. And again, the key message of this campaign is pain is personal, but treating pain takes teamwork. So we want you to choose more movement and better health. The hashtag #ChoosePT resources that are online help consumers have conversations with their healthcare providers about the best treatment plan for them. That includes their physicians, their nurse practitioners, their pharmacists, their therapists, their social workers, everyone working together as a team to help them solve their problem. The website will link consumers to resources specific to conditions they are dealing with. And this information helps them improve their visit with their provider. Okay. Make sure that comes off. In 2018, the APTA convened a panel discussion with 7 unique perspectives on the opioid epidemic. The Beyond Opioids event was broadcast live and stressed the importance of collaborative care, including physical therapy, to successfully and safely manage pain. Also in 2018, APTA published a white paper about how physical therapy can transform pain management to improve health. It emphasized studies that have established the efficacy of physical therapy in treating and reducing pain, as well as preventing chronic pain. In January 2020, the APTA published an update to this white paper as a follow-up to their first in 2018. And it clearly stated the opioid epidemic is a complex problem that will be solved only through multidisciplinary collaboration. When PTs work with patients in pain, they use tests and measurements to determine the causes and the impact of the pain. They also assess the pain pattern, intensity, impact on function, and quality of life. PTs also evaluate individuals for risk factors for pain to help prevent future pain issues. These risk factors can include conditions such as arthritis, diabetes, neurological conditions, which can affect an individual's pain experience. Also, disorders such as anxiety, depression, fear, post-traumatic stress disorder can be risk factors for the development of chronic pain. Also, a person's negative beliefs about their condition can contribute to persistent pain and a belief that hurt equals harm. There's also a strong association between immobility and chronic musculoskeletal conditions such as pain. Once the contributors to the patient's pain are identified and the patient's goals are ascertained, the PT designs an individualized treatment program combining the most appropriate techniques, including but not limited to therapeutic exercise, manual therapy, and patient education to address the problems. Studies have shown that people who exercise regularly experience less pain, and physical therapists can develop, administer, modify, and promote exercise prescriptions to address poor conditioning, impaired strength, musculoskeletal imbalances, or deficiencies that may lead to pain. Also, manual therapy can be used, which is hands-on movement of joints, muscles, and other soft tissues to modulate pain, to reduce swelling and inflammation, and to improve mobility. And research has shown that manual therapy techniques are effective in reducing low back pain and discomfort associated with things like carpal tunnel syndrome and other sources of pain. Patient education is very important, and addressing activity pacing, posture, ergonomics, self-care strategies, and activities of daily living also assists the patient, the individual, in controlling their pain. We also incorporate interventions such as mindfulness and relaxation and visualization and graded exposure to stress-producing events, which can help patients reduce pain and improve their functional capacities. Sleep is also very important, and individuals with persistent pain often complain of sleep disturbances, and PTs can help educate patients regarding appropriate sleep positions to help combat the vicious cycle of persistent pain. How many of our patients sleep in their recliners? PTs can also educate patients about how pain works. What's the current science of the cause of pain and the cycle of pain? And by empowering the patients with this education helps them on their journey to overcome that pain. And of course, all of this will be emphasized when Holly Johnson goes over this in more detail. This is a portion of a one-page resource from the American Physical Therapy Association, which reinforces the research showing from the Journal of the American Medical Association that exercise and education can prevent low back pain, or from health services research which showed patients who accessed a physical therapist at the first point of care had lower utilization of high-cost medical services, lower opioid use, and lower healthcare costs than those who saw a physical therapist later in their episode of care. The journal Spine showed that early physical therapy was associated with decreased use of advanced imaging, additional provider visits, surgery, injections, and use of opioids. The Archives of Physical Medicine and Rehabilitation showed that early physical therapy for acute low back pain reduced health service utilization, reduced cost, reduced opioid use, and improved healthcare efficiency. JAMA also showed that early physical therapy was associated with significant reductions in long-term opioid use and lower amounts of opioids for patients with shoulder, neck, knee, and low back pain. And lastly, the Clinical Journal of Pain showed that early PT was linked to reduced risk of long-term opioid use. Why is this important? Combined with all this information that we talked to you about with research, in 2017, Time Magazine had an article that shared that 78% of Americans surveyed really indicated that they have a preference for non-drug approaches for pain control. And when I researched this today and in preparation for this, this presentation, everybody's referencing that pre-pandemic information of 78%. So again, the majority of people in the United States want to have something other than drugs address their pain. The US Surgeon General recommends the CDC guidelines for pain control and produce an informational digital postcard that notes that treatments other than opioids are effective in managing pain and may have less risk for harm. The information just presented to you supports best practice, less opioids, and more movement, which leads us to our next speaker, Holly Johnson. Holly, I'm going to stop sharing, and you can take it away.
Can you hear me? Okay, guys?
Yes.
Okay, great. Thanks, Mike and Charlie. It's great to be with them. We've worked together for many years. I'll tell you a real quick spiel on my background, and then we'll go for the end of the presentation here. I've been practicing 35 years, a UK graduate, and 32 of those years were in Eastern Kentucky in private practice. So I was one of those people that was kind of at the ground zero for the opioid epidemic, working with coal miners and lots of families and women's health and sports medicine, but went underground every year and just really watched in that 32 years some patients die from chronic pain overdoses, of opioid overdoses, drug deals, just some really scary things. So that's kind of been my passion over the last half of my career. For the last 2.5 years is I'm actually doing physical therapy in addiction recovery with ARC addiction recovery centers that are all over the state now, but actually started in Louisa. And so I treat women in addiction recovery and do research with the University of Kentucky on the effectiveness of physical therapy with people with musculoskeletal pain, acute, subacute, and of course we deal with a lot of chronic pain, because a large portion of people that got addicted in Kentucky started with either marijuana or opioids as a treatment for pain. So it's just been amazing for me to be able to share. I'm just thrilled to share with you today some of my new research findings. And I only have a few minutes here, so Charlie and Mike have set a great table for me to give you some overarching views that I think will hopefully help change or even encourage your good decision-making process. So glad to see so many different healthcare providers, behavioral health, and administrators on this call, because that's what it's going to take in Kentucky for us to really make a difference. So we want to be sure that you come away from the rest of the presentation knowing what you should expect from physical therapy, and feel free to ask us questions, you know, as we move along here. So what's new on the horizon? So the big thing is that PTs have always been in the front line of treating musculoskeletal pain, but we have a lot of new information over the past 15 years and even the last 5 years on pain neuroscience education. And Mike did a great job about talking about that. And I'm going to tell you about why that is so important, because we've got to be, whether it's in the ED setting, as Charlie said, or in inpatient or outpatient, or now even in the addiction recovery care setting itself, we have to help people address their musculoskeletal pain. Because if the brain produces pain for a reason, it's telling us to take care of the problem. And so when we give people opioids, all we're doing, guys, is covering up the problem. It's as like when I was in college and I hated the Volkswagen that my dad made me drive to UK, because we got it when I was in the first grade for $1,000. And so when the check engine light came on when I was, I guess, a sophomore at UK, I put a piece of tape over that, because I just decided I was sick of that car. And it's the dumbest thing. Anyway, I blew out the transmission because I just ignored that signal. And my dad was so mad at me. It didn't go well a little while at our house, because he didn't think I was very grateful for that, 20-year-old Volkswagen that I got to drive. But anyway, we got it fixed. But my point is, that's really what we're doing. We are continually in the United States putting the Band-Aid on our musculoskeletal pain with opioids. And it's just, as we say in recovery, how's that working for us? Not too well. So what we really want to talk to you all about as PTs is really looking at, and really what my research shows, is this formation of teams of a really good PT that understands neural pain science and good primary care and good counseling. When we get that combination of all three, the people I'm treating in addiction recovery, their chronic pain that they've had for years is going away because they're detoxed off all their medications. And they can really get to the point of getting good PT treatment, maybe for the first time, because they may have failed other treatments because they were using, and getting good counseling. But that combination, and then primary care people coming around them, understanding why they can't take those drugs anymore, they're just doing beautifully. And so that's kind of new information to us. So what we found is that PTs, mid-levels, physicians, and behavioral health, we have to understand musculoskeletal pain, that the brain produces it for a reason, to get a problem solved, not to cover it up with opioids. And we have to understand this concept of central sensitization, which is a big deal. That's really what Mike was talking about. When we're dealing with the brain sometimes produces pain for long periods of time after the injury should be healed. And I'm going to show you a little slide on that. We could do a whole course on that. And we do it, actually, our chapter is offering a course on this with more details, but I want to give you at least a tutorial today. I spoke at UK a couple of years ago to all the clinical administrators and the clinical, medical PT behavioral health administrators for the state. And I asked in a group of 500 medical providers that were providing clinical education to our new grads, how many of you all have heard of the term central sensitization? And I'm not kidding you, 10 people raised their hands out of 500. So that really told me, even 2 years ago, we got some work to do on educating people. This is really common when people are stuck on opioids for a long period of time. High percentage of these people have central sensitization, meaning that the brain is continuing to still produce pain for various reasons that are being unaddressed. So also, we have to understand substance use disorder and the way that it is a brain disease as well, and the neuroscience of that better. And then we have to understand trauma-informed care, just understanding that people have been through some very traumatic things in their lifetime, and it affects their brain, and how the brain also continues to produce pain. And guess what? COVID made that worse for most people. So I think it was Charlie that did a great job of showing the OD problems, the overdose deaths in the United States and Kentucky. And we're always lagging a year behind in stats, but the new stats for 2021 have just come out, and we are now over the 100,000. I think it's like 104,000 OD deaths in the United States. So we're still going up, and that's with Narcaning people. We have learned to Narcan and save millions of lives, but we are still having a horrible OD problem in the United States. And like Charlie said, in Kentucky, depending on how it's reported, it has gone up into the 50% range. So if you want to know how your county's OD deaths are doing, here's a link for you. You can just go click that link, and you'll be able to tell in your community how your OD deaths ran last year, if they're going up or down. But in most cases, in most counties in Kentucky, they have gone up. So I want to just look at the details of this a little bit more. When you're talking about natural and synthetic opioids, so that's like, morphine, codeine, hydrocodone, all the oxycodones, those really increased. Remember, with the Oxycontin crisis, remember in our community in Harlem was ground zero for that. And West, Eastern Kentucky and West Virginia kind of targeted, by the Sackler marketing groups because it was a population that was kind of an undereducated and highly industrial. So all my patients, were put on Oxycontin back then. And then we kind of dealt with that problem and then kind of plateaued. But guess what? We're going up again, guys. After COVID, we are coming out of COVID, we are going up. See my little arrow here? We are still seeing increases and that's after the CDC did all that great work that Charlie talked about to decrease opioid prescribing practices. So we've still got a little problem here, but we've got a bigger problem with synthetic opioids, and that's really our fentanyl problem. So I see a lot of that, weekly in my practice. So the synthetic opioids, people have gone some from the natural and semi-synthetic to fentanyl, and we know how dangerous that is. But the other huge problem is our meth problem. And I didn't put a slide in here, but there's an equally scary slide now on the CDC website that shows in the United States, our meth overdoses have gone up by 54% this year. That's really scary. And a lot of the people I'm seeing are meth users and Suboxone users. So they're being treated with an opioid, which is MAT, medically assisted treatment, that they might get for treating their opioid problem, except it's backfiring on them and they're now using it with another opioid. So Eastern Kentucky's kind of ahead of the curve there and seeing some problems with that. So that's what I'm dealing with in my research. What are the best practices there? So bottom line on this slide, what we need to know as healthcare providers is that our natural semi-synthetic opioid use is going up slightly. Our synthetic opioid use is skyrocketing, and our meth and Suboxone use are going up in large amounts. And that affects all of us because we're spending a lot of money on this problem. So why is physical therapy such an important piece of this puzzle to help solve this puzzle? And it's because, again, Mike talked about it, when we evaluate patients, we look at their whole body. We look at all their musculoskeletal pain at one time or others. We don't treat people and say, oh, Ms. Smith, we're just going to treat your neck today, or we're just going to treat your knee. We have to treat the whole thing because the brain's producing pain. If we're going to get rid of that pain, we have to address all the areas of pain. And we have to be aware of people, if they've had trauma and they have emotional trauma, that they might need counseling at the same time. And we're seeing if they get those two things together, it's just like a home run for treatment. So in physical therapy, we have to treat the whole system, the whole musculoskeletal system. And remember, that's one of the top reasons people are in the ED or in primary care offices, except for maybe, common cold or respiratory stuff in primary care. So guys, if we can get this piece right as treatment teams, we can make a huge difference in Kentucky if we can learn to say we're not going to put the Band-Aid over the problem of opioids. So again, we got to evaluate the whole person. We have to think about trauma-informed care, and we have to look for reasons why the brain may be continuing to produce pain after the injury may have looked like it should have healed, and to identify if things have not been properly addressed. So this is one of the first things when I teach an elective at UK on this, and we're also going to be teaching a course, a 6-hour course, a APTA Kentucky chapter course. If you all want more information about it, I'm just going to give you some of the basics today. But this is one of the first things we look at is the mature organism model. And it really does a great job of saying, your brain is this big computer that scrutinizes all the information out there. So when you get a tissue injury, that like a sprained ankle, back issue, whatever you want to do, your body has receptors that gives information through your nerves up your spinal cord to your brain. But at the same time, your brain is also analyzing the environment in which it happened. It's saying, has this happened before? Is this our first car accident or our fifth? Did I feel safe? Was I abused? Was there emotional trauma? Your brain takes all that into consideration, and then it decides how much pain it's going to produce to protect you. And that's the really basic pain neuroscience 101 that we all have to begin to imagine. And not just imagine, but to understand and explain to our patients that their pain is not in their head, it's real to them, but we have to treat it as from the top down, not just from the injury level up. And that's what we've been doing with opioids all these years. And that's part of the reason why we're failing for some people. So remember what Mike said, how many people, hold up your fingers, 1/5 of all people in the United States adults have some level of chronic pain, and they really do want other solutions, but we've taught people in the United States that a pill is the answer to your problem. And it's really not. It's lots of times the covering up the Band-Aid that will actually help your musculoskeletal pain problem get worse. And that's what we have to change if we're going to have an impact on this. So what is this term called central sensitization? You're going to see some complicated definitions, and I'm going to walk you through one and try to explain it a little bit. And again, more if you want more, there's plenty of stuff out there, plenty of books, and then we're teaching a course on this too if you want more information. But it's that condition where the central nervous system is associated with how it develops and it maintains pain, especially chronic pain that's over 3 to 6 months. So centralization is really this wind up of the central nervous system. And then that system gets regulated and it just holds that high persistent level of pain threshold. And so what happens is it's like an alarm system. If somebody broke into your house and the injury occurred, the thing occurred, but nobody reset the alarm system. That's really what good pain neuroscience does, is it helps reset your alarm system through physical therapy and then actually doing exercise, hands-on manual therapy work, getting the person strong again, in better condition, or what all the things that need to happen to help heal that area or areas. So instead of letting the central nervous system stay in that wound up, high regulated state of producing pain, like an alarm system that just won't go off, that's just annoying, the fire out of everybody. So it's as if, again, before the injury, you could do all kinds of activity, but after the injury, it just does, because your alarm system is broken, it just takes very little activity and your back hurts. And this happened to me. I had a back injury that went on, and I should have stopped and gotten myself treated. And as a PT, I kind of halfway treated myself, and my system got regulated. So I know what this is like. It's really common for chronic pain. So 1 in 4 people will experience some level of central sensitization, and then they have a choice. Are they going to drug that problem, which I didn't, but it was sure tempting when it goes on for a couple of years, or are you going to stop and get treated with physical therapy and maybe even counseling to help take care of the problem if that's needed? So what PT does is it addresses central sensitization with an evidence-based approach to pain neuroscience. So we come along with manual therapy. We work on the area with our hands to get the joint moving properly. We do therapeutic exercise to build that area up, to get it strong, again, to get it flexible, to get there's some more stability there, depending on whether it's neck, back, knee, shoulder, hand, foot, you name it, rib area, whatever. And we're going to immediately that day give a person a home exercise program to take responsibility so that they know that's their medicine that they take, not a pill. If people come to PT, they're never going to get a prescription. That's why early intervention and direct access is so important and has been legal in Kentucky for, gosh, as long as I've been out of college, which is 1986. And that was because I was 12 years old, of course, when I went to college. So don't want y'all to think I'm old. But I'm saying that's been around a long time. So, but patients would much rather put a pill in their mouth because it's sometimes cheaper and easier and more convenient than them actually having to do something. And that's the hard part for us as medical providers, to sell that to them, that we really want to offer them a permanent solution. And we do opioid tapering programs. In my research, people are already tapered off opioids, and we're developing Suboxone tapering programs too, which are highly effective. And then, of course, we use other modalities too, dry needling, e-stim, all that stuff too. But we are only a part of the trauma-informed primary care and behavioral health team. So you primary care people are so important that you understand this, that we're all working together as a team, and that our behavioral health people are working on doing that trauma-informed counseling if a person needs it. And that's really what my research shows, is hitting the ball out of the park. So what we really hope is that as a result of us in Kentucky addressing our opioid crisis, that we'll form these teams and then they'll work. So we want to be sure as physical therapists that we're offering all ourselves as PTs, PTAs, but also all medical providers some tools. So at my elective at UK that I teach third-year PT students, we have developed a toolkit that's available, that's to be used for patients, their families that are struggling with opioid use, or the primary care docs, or orthopedic surgeons, and also behavioral health. So it's definitely forward facing for all those groups. And if you're interested in that, there's the website there. The PAs actually have purchased our toolkit so they can get their own version right there at that website. But please join that effort and just look at those tools. So what those tools do is give you 15 lessons on how to explain to your patients why opioid use is not a good idea for treating musculoskeletal pain long-term and why PT is the best choice. We have lessons in there on what is central sensitization, how do you treat it? Also the things that Mike talked about. We have 15 different other lessons on how do you learn to sleep, how do we teach people to sleep better, to have better nutrition, to be lifelong exercisers? How do we teach people with chronic pain how to do graded exposure, which is how do I clean my house or do my yard and that I don't keep injuring myself over and over. There's some really cool lessons, and every year my students will then update. We have a new elective this year, so we'll be updating that again. So, and we love suggestions. If there's more things you want us to address, we'll do it. We want you to be able to easily do a PowerPoint with your patient and have a handout to give, and even homework that you want to, give your patient to help, because that's treating their brain and helping them understand that this pain, this alarm system can be turned down in physical therapy and with counseling. And primary care needs to know that too, because you have to encourage the patients to actually go and stick it out in PT, and that motion is lotion and they can be sore but safe, and they may get a little bit sore, but we're not trying to blow past their pain either. We want to respect that. So we have the toolkit for you. And then we also have Save the Day. We are doing a course, a 6-hour Zoom course on this very topic, holistic treatment for musculoskeletal pain without opioids, on August the 13th. And just check we'll send out a flyer through this group and through our association. And then on my website, I also have some free tools. If you ever want to do some evaluation tools, are on there too. So let me stop sharing and we will turn over for questions.
Terrific. Thank you. This is Emily Henderson again with the Kentucky Hospital Association. We have a chat in the chat box that we can address, please, from Dr. Ron Stanton. If one of you want to read this, it's regarding insurance and for referrals, please.
Dr. Stanton, that's a good question. And fortunately, many of those barriers are coming down now. Many private insurances recognize the benefits of direct access to physical therapy. CMS, while they recognize direct access, they still have a requirement for a physician or a non-physician practitioner to sign a treatment plan initially. Now, a patient can be evaluated and that treatment plan be signed afterwards, but you don't have to have that same physician. We can refer to the primary care provider. It's not a requirement from a CMS standpoint for the provider to actually have a visit before they can start physical therapy. So it's guided state by state. Kentucky is a direct access physical therapy state. So while there are still some nuances to make sure that all the T's are crossed and I's are dotted for coverage and reimbursement aspect, I think we're moving in the right direction to have more direct access. I don't know if that answers your question directly or not. Hopefully so. If not, I can follow up with you offline.
Well, and I know Holly has worked with reimbursement issues for many, many years on behalf of American Physical Therapy Association Kentucky. Holly, do you have an update on that?
I don't, but that's probably something we need to bring together. That's the kind of thing we need to know. That's why we do these things. So we can bring that up to our chairman, that we need to redouble our efforts on that. So at the moment, there's not anything new, but we can, we'll definitely take that to Beth, the Dr. Ennis, at our next meeting. So thank you. That's the kind of things you can always send to us.
Great, thank you. Are there other questions for the presenters today? Either unmute yourself or type in the chat box at this time. Kentucky SOS.
There was one from Bob about, I think he was looking for the toolkit and it said it was asking for a username. What we need to do is I will send an email out to our executive director to be sure that people may be looking on that are non-members. So just text, just email the Kentucky, that website there, and just tell her that you want to purchase the toolkit. And there's a whole, there's kind of a tutorial at the beginning of it in front of the firewall, so you can make sure it's something you want, and then you can purchase that if you want to. And that goes to support our chapter. So we'll get on that. Thank you, Bob, for looking.
Okay, thank you. And Kentucky SOS thanks the physical therapist today for getting approval for continuing education for all of the physical therapists on this live webinar. You see the CE statement for 1 hour credit for today through the APTA Kentucky chapter. So thank you so much for that. I know our hour is coming to an end. These slides and the webinar recording will be posted on the Kentucky SOS website. Once that's posted, I will email it to all the project leads. I did put my contact information and the Kentucky SOS website in the chat box. If you're interested in getting on the Kentucky SOS email distribution list, just let me know. Have any questions, or if you think of questions, please send them to me and I will send to the presenters to get answers for you. Thank you so much to Charlie Workman, Mike Muscarella, and Holly Johnson for your time and expertise. And Kentucky SOS, we're ever expanding, always growing, and we appreciate this multidisciplinary approach of including physical therapy as an alternative to opioids. And thank you for your time. Everyone have a great day, and we'll see you next month on our next webinar, which will be May 10th. Thank you.
Thank you, Emily. Thanks, everybody.
Bye.